Welcome back to another episode here on the Hard Hustle Podcast. Our next guest says the communities who've had the least are leading the future of healthcare, and now they're just waiting for innovation. However, we're building it ethically with what we have, says Dr. Hannah Galvin. Doctor, appreciate you joining us here on the Hard Hustle Podcast. I've got to ask you right into the first question. You got one foot in tech and one in pediatrics. What's the connective tissue between those two worlds?
Yeah, I love it. Thanks for having me, Evan. It's great to be here. Yeah, so there's a lot of connective tissue. We are using tech to move pediatrics and other specialties along kind of the speed of light here at Cambridge Health Alliance. We're using generative AI, we're starting to look at agentic AI, and we're doing it all with an equity lens. Cambridge Health Alliance is the only public health system in Massachusetts. Almost 50% of our patients don't speak English as their primary language, and as we're using these new innovative tools, we want to make sure that we're serving all of our patients at different age groups throughout the life cycle and across care settings, and that we're doing it in a way that has an eye toward equity and to serving patients where they are. So it's really important that we are not just using the technologies because they're out there, but we are understanding what our patients need and then using the right technologies at the right times in the right settings to meet our patients' needs.
I ask you, what moment in early on in your career actually made you realize equity in care wasn't optional, but it was actually more personal?
Yeah, when I was in high school, I spent some time at a clinic. I spent some time in both an emergency room that served a vulnerable population, the Children's National Health Emergency Room in D.C., which is where I grew up. I grew up in Washington, D.C. with a lot of very underserved and ethnically diverse populations. And I also worked at a clinic that was a stand-up clinic in a church basement once a week, where we sort of popped up this clinic for homeless and at-risk individuals who did not have health insurance, and just provided free care. And that's where I learned to take a history and perform vital signs. And I watched as doctors volunteered their time every week to take care of these vulnerable populations, and realized that and really learned from these doctors that that is what medicine is about, right? Is serving the most vulnerable and providing not just medical care, but providing providing for their other needs. So we would give food. We had a food pantry there, and those were some of my early experiences in medicine, and I think that informed all that I do today as well.
And tell us a little bit about the organization you're with today.
Yeah, so Cambridge Health Alliance is the only public health system in Massachusetts. It's Harvard's safety net health system. Our mission statement is equity and excellence for everyone, every time. We have 3 hospitals, 2 acute care hospitals, and a behavioral health hospital. We have a very large behavioral health footprint, understanding that behavioral health is part of one's overall health care. As I said, almost 50% of our population does not speak English as their primary language. We are an academic health system, but we are also a safety net health system. And so we sort of bridge that sort of chasm of working on advancing sort of the cutting edge of academic medicine, but also, right, we have a really strict bottom line, right? We are really challenged with our budgets and serving a patient population that is about sort of an 85% public payer mix. So how do we do that? We pride ourselves on being very innovative, but at the same time, we need to prioritize what are the most important areas to invest in that will have the best outcomes and the highest value for our patients.
I ask you, Hannah, before you get into this world of just healthcare, what did you want to do? Do you always see yourself here? Or is this like you just following in the footsteps of a family, or you just realized it early? It's like, wait a minute, I got to do something about healthcare, and you just loved it.
Yeah, no, my parents were not doctors. Actually, both my parents worked for the federal government. I think I sort of picked up some of that, I would say, desire and understanding that we kind of all exist in this country and this culture to sort of help and serve one another from them, and from sort of, as I said, growing up in DC and understanding that, I think my sort of perspective is that the goal of government in this country is to serve, and serving sort of those who can, who are struggling the most is what the goal of anyone who has more in this country is and should be. And so I think that's what I picked up early on. I think I wanted to be a teacher because those were the people who I think made a huge difference in my life as a young child. But I figured out pretty early on that I wanted to go into healthcare. I think around 9th grade or so, when I started to learn about biology, and that really interested me. And research, and biological research, and I spent a lot of time interested in that, and that's when I started working in health clinics and volunteering in health clinics, and I really just fell in love with it. I fell in love with the idea of serving and caring for patients, and so I knew right away when I went to college that I wanted to be a physician and that I wanted to serve underserved communities, and so that's been a theme throughout my journey, that those were the populations that I felt called to care for and to serve. I did not know at the time that I really wanted to have so much of a technical bent, although during my childhood and growing up, I was always sort of a techie kid, right? I sort of grew up in the computer age, and I was always the kid that my friends' parents turned to sort of help fix their computers and things like that. And so in college and medical school, I got campus jobs, work-study jobs on the tech side of things. So I wrote websites, I worked at the help desk, and things like that. And also in medical school as well, I was doing tech work. So when I got out of residency, that was right around the time of meaningful use. And it turned out that, they were looking for doctors who had a technical background, who could help with the rollout and implementation of electronic health records, and they tapped me because it just came easily to me. I wasn't a computer science major, that hadn't been a major interest for me in college or medical school, but it happened to come easily to me, and so they tapped me, and then I realized all of the amazing system-wide changes that we can make and the system-wide advancements that we can make using technology, and that's really where the two kind of married.
When you think about technology, as you mentioned, growing up during those times of computers, same, right? And I think if I wasn't doing what I was doing, maybe tech would be what I'd be doing. I just realized yesterday I bought a new mic, wireless mic. And first of all, the way that these wireless mics look like now compared to what they used to look like, it's crazy, right? But I'm sitting here with all these gadgets, and I'm buying new computers, and I'm building a PC. Mind you, never in a million years would I thought I would have built a PC. I used to make fun of people like, you built a PC? What do you mean? Realizing, no, the benefit of it actually is, right? So I'm getting into this world of technology and realizing if people are not doing tech, like if you're not going to go to school for healthcare, technology is one of those things that are not going away. The advancement is there. I was talking to a young girl and she says, yeah, the only thing I could take was technology. And I'm like, that's great.
Yeah.
That is so
That'll
good.
serve you.
That means you have a job for life.
That's right. That'll serve you well, right? Exactly. And
No,
it's just
I love it.
continuing to advance, right?
And we talk about technology in the healthcare. I speak to a lot of leaders in the healthcare and the nonprofit space. Technology seems to, while it is here, it seems to kind of lack in those organizations. Is there anything that you're kind of excited to see down the pipeline? I mean, we talk about AI. Is that something that you guys are looking towards? How is healthcare advanced? Let's talk about the last 5 years. How do you see healthcare advancing in the last 5 years, and what does it look like for the next 5 years?
Yeah, so I think, right, even starting like 10 years ago, it was all about implementation, and then it was about optimization and integration and innovation, and now, right, it's about automation, right? So now we're sort of in this age of automation with AI, and even in the past 5 years, or even I would say right in the past 1 to 2 years, right, we've gone from looking first at sort of predictive AI and what predictive AI could do, to then starting about two to 3 years ago to generative AI. And now we're really moving into agentic AI and what agentic AI can do for you in sort of automating tasks and taking tasks off people's plates to continue to let people work at the top of their license, but also to allow processes to run more efficiently and quickly and improve patient experience of care, so people aren't waiting on hold with scheduling centers as much, because they can take care of more through a chat agent. And so I would say that's where we're moving, is into much more automation. And there are pros and cons to that, right? We all have experienced, I think, in the past probably 10 years, other industries moving into automation, right? You call your cable company, and the cable companies have sort of automated voice agents that answer. And that is great because they can route you to the right place, and they can answer some of your questions, and they spend less money maybe on people to answer the phone, and those people can be doing other things or cross-trained to do other things to help you out. But also, people get frustrated when, an automated voice agent answers the phone and doesn't understand you. Same thing with banks, things like that. And so we have to be careful as we implement some of those tools into healthcare to make sure that we are actually caring for our patients appropriately, and that patients, that there's no miscommunication with that, and that everyone is cared for safely as we implement those tools. Most importantly, that everyone is cared for safely. And so I would say that is how I see what has happened over the last several years, 5 years. So.
Yeah. No, that's good. And you kind of mentioned that like chat agent picking up on its own. I was in the airline industry during pandemic, where everything was kind of shifting, and realizing that we're starting to implement some of these things, when you chat with us. So now a lot of your answers were really, a lot of your questions were actually answered before you even got to a live agent. So you've never had to get to the live agent. Like, that's how good it is. And I think what people, oh man, I just actually had someone really good write me yesterday. So when I spoke to this lady, she was so afraid of AI. And when I say AI, I'm talking about ChatGPT. Like, that's the most basic of the basics, right? So she was, when I got on a call with this coaching, on this coaching call, and this lady was like, no, I would not use AI. And I'm saying, but what you're doing is you're paying a company, right, all these thousands of dollars, and I can imagine that they're using AI to build your brand in really their voice, because it's not your voice. So I'm showing her how to actually take some of these things and put in her voice. And this was like a week and a half ago. Yesterday, she texted me on a Sunday. She says, hey, I just want to let you know, thank you so much for all the insight that you've given me. I think I'm overusing it. But it's like, you really can't overuse it. It is truly there to help you. And to, as you mentioned, just allow us to do things a little faster. Things that we do tend, especially in healthcare, things that take us, take time away from us, instead of actually being able to work with that patient. Why can't we automate that? Because let's be honest, and I know you didn't go to college and to a nice university to sit here and do admin work and all this paperwork. It's like, no, that's not what I wanted to do. I hate this, right? So I think it's a great place, and I'm loving that you're in the healthcare space and you can see the vision, because there's still some people. My mom's in the healthcare space, and I says, Mom, have you ever used ChatGPT? And she's like, what is that? I'm like, oh my God. So, it's not, everyone's not adapting to it. There's still some challenges, but I feel like when people are actually utilizing it, they're educated around it, that it's making a difference in their lives and also in their work lives. And I'm happy, Hannah, that you guys are kind of in that space, especially you, because of the tech background, in the space of seeing how it really does become a benefit, and how we could serve more people in our communities in 30 different languages, probably, right?
Yeah, and I would say, it really can be a benefit, and the American Medical Association is actually starting to call AI augmented intelligence, right? Because it's helping to augment the things that we are doing, which is I think a really great term for it. But it has to be used carefully, right? And when we think about how we are using it here at Cambridge Health Alliance, one of the things we start looking at is First starting with efficiencies and how can it, as you say, take away some of that administrative work. So we have implemented a generative AI tool integrated with our electronic health record to help providers write notes. So we were early on in that, and we've had that implemented now for a year and a half or more, right, to take some of that burden off of providers. There is little safety risk to that because providers are reading the note over and making sure that whatever the generative AI tool drafted is correct, right, and actually happened in the visit. We are using an AI tool where we actually are development partners with a few companies, and we're developing a tool that is a medically context that is a translation tool that is appropriate for the medical context. So if you look at some of the translation tools that are out there, like Google Translate, they're very good translation tools, but they're not trained on medical data and so and medical terminology. And so when you try to use them for medical translation, they're not as good and maybe not appropriate to use for sort of patient discharge instructions and things like that. So we're working with a company and helping to train the model in sort of medical context language translation. We are also a development partner with a company that will translate our phone trees, right, for our patients with many, many different languages, and specifically our top 3 or 4 languages. And we are using radiology, an AI tool for radiology, for triaging radiology studies, where it's not reading the radiology study, although we have tools that help with that as well. That's really sort of standard of care these days. But we'll take a look at all the radiology studies in a radiologist's queue and say, hey, this one needs to be looked at first because this patient has something that is really, really significant. Where AI hasn't been used or tested significantly yet is in like making a diagnosis, right? So there's a lot of anecdotal reports right now of people sort of typing their symptoms into ChatGPT and it spitting out a diagnosis. And there have been a number of studies where people have used ChatGPT or similar sort of large language models in answering boards questions, medical boards questions, or with clinical vignettes. But there aren't studies out there showing how that works in real life, like in the clinical space, and actually seeing patients. And so we are starting a study where we're going to look at ChatGPT and a few other large language models and how safe they are in answering medical questions in real life, which I think is really important to look at because you want to make sure that when you're using these tools, you're using them safely.
Hey, real quick, if you're enjoying the podcast, we first want to say thank you. And we also just want to give you a little insight of what we're up to at FRANSiS. Some don't even realize that we're working with organizations to help them use AI to create that real human communication experiences, whether that's actually supporting your families, those patients, or the entire community. We're actually creating tech that connects. Check it out, francis.ai. Correct. Yeah, people are using them. I spoke to someone that said her daughter is using ChatGPT more as a therapist. So, it's happening.
And it's definitely happening. And we're also hearing reports of people who are using it as a therapist, and it's not giving great information, right? It's telling the patient, people things that make them more depressed or make them suicidal. And so we want, right, I think they are fantastic tools, but we also want to have guardrails up to make sure that people are able to use them safely. And so it's, that's my job as the Chief Health Information Officer, is to make sure that we have good governance around these tools. We want to be on the cutting edge and we want to innovate, and we also want to make sure that we are using the tools safely and not, and right, as a doctor, never doing harm. That's part of the Hippocratic Oath, right? And so that's it's a tricky balance to walk in this really like new and innovative area where we've never been before,
And how patients accepting this? Like, are they responding to the AI tools as in they've appreciated? Are they still kind of concerned? I mean, you being a part of that, what does that look like?
I think many patients are very excited about them. Every time I go in and see a patient, because I practice as well, right? Every time I go in and see a patient and I use the tool to record the visit and it helps me write my note, they love it because I can make better eye contact with them,
Yeah.
right? I'm not looking at my computer the whole time. And especially for our patients who don't speak English, it's really helpful to be able to get those non-verbal cues, right? And take, look at them, whereas otherwise, right, I'm sitting here, I'm like typing on my screen at the same time, and that I'm in the visit. And so I think patients do really like that. And I think there's also a healthy skepticism too, to make sure that, they understand what's happening. So I think it depends on the tool, right? The note writing tool has
Hmm.
been relatively well accepted. And I think that as we look at different tools for different purposes, I think that patients want to understand. They want transparency into what tools are being used, and rightfully so, and how those tools are using their data. And we have a really robust governing process that includes understanding the model, but also understanding the security of the tool and how data is being used, and
Yeah.
maintaining the patient's privacy. And I think it's really important to be transparent with patients about how their data is being used, and how the tool works. And we try to do that. And it's
And
important, oh, sorry, just to add, right, I
right.
think it's important to do that in order to maintain trust, because trust is so key to the patient-provider relationship and to the provision of healthcare.
Okay, and so hearing that from the patient side, but I always feel like when you're implementing something new in a company, you definitely get that pushback. But it seems like you guys have a couple of different AI tools out there that
Mhm.
I can only imagine there was some pushback. What was the pushback, and are those same pushbacks still happening, or are they realizing, oh wow, why was I pushing back? This is actually really great.
From patients, you mean?
Oh no,
Um,
just your staff, your
Oh, the
team.
staff? Yeah. I think that there. I think that for the most part, the tools that we have implemented have not received a lot of pushback,
That's good.
um, because we have vetted them so carefully before we've introduced them to the organization, and then the communication plan with the organization has been, um, really robust, right? Helping the organization understand why we are using the tools, the fact that they were vetted, and providing that understanding, and the fact that we put in place a pilot first to test the tool, make sure that it was validated, internally validated with our patient
Hmm.
population before scaling the tool. So we haven't received a lot of pushback in that regard. I think that if anything, many of our staff may want to try out many new tools that we may sort of lock down a little bit and
Hmm.
say, whoa, 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 we have to vet that a little bit more before we can sort of let that loose. So if anything, I think people are more excited to move forward with AI than we're quite ready to do, and we want to put some guardrails around it.
I love it. Yeah, you guys are definitely ahead of the game. There's not a lot of people that speak so highly of AI and implementing so many things in such a short amount of time. And I wouldn't, while people think it's a short amount of time, AI has been around for a very long time, and you know
Yes.
that. It's
Yeah,
just
yeah.
that we're now calling it
It's
that
now
sexy
at
word.
the
Everyone, yeah, it's talking
top of the
about it.
hype cycle. Yeah,
It's been like, I mean, I'm pretty sure you're into music, but when we
yeah,
talk about underground music, and then all
yeah.
of a sudden that underground music artist becomes, this pop icon, it's like, I've been listening to that person, right?
Yeah,
So
yeah.
you
I've been
probably
doing
already
that.
had.
Yeah, exactly. Exactly.
I love
Yeah.
it. Do you think there's a misconception in healthcare leaders have about data sharing that actually drives you nuts? Because I think that's also really important when we talk about
Mhm.
data.
Yeah. Yeah, I think that's a great sort of other area to sort of talk about. Yeah, I do, and this is a lot of the work that I lead nationally is around interoperability and data sharing. And I think that one of the misconceptions we have is that sharing data indiscriminately, and the more data that we share, the better off we are, right?
Yeah.
So we have been building this ecosystem of data sharing now for probably about the past 15 years. And in many ways, it's really great, right? The benefits of this are, right, to be able to care for our patients better as they travel to different parts of the country, right, or to different health systems. And if I see a patient in Massachusetts and then they go to California, and being able to access their data in different places and to be able to provide that care, to decrease costs because I don't have to repeat tests because I can see that they got a CT scan already, right? So there are a lot of benefits to this, and I think that has led us in many ways to say the more data that you can access, the better. But I think there's nuance here that we often don't consider, and I think that um, I may have maybe more insight to some of this nuance because of the populations that I work with and have worked with my entire career. But what we know is that for many people, having all of their data shared cannot be a good thing. And I'll give you an example. So I was doing street medicine for a number of years, and I would see patients on the van, the van where we saw patients and provided clinical care. And we would often need to send them over to the emergency room if they had acute trauma, things like that. And I remember seeing one young man about 21 years old, and he had been hit by a truck. I needed to send him to the emergency room to get a CT scan. And he said, I can't go to the emergency room because they're going to see in my chart that I have a history of opiate abuse, and they're going to immediately say, you're just seeking drugs, and dismiss me. And that is the experience, unfortunately, of many, many, many people in our health system. And they understandably have mistrust of our healthcare system. And when their data precedes them, they don't want to seek care. And that becomes a real barrier to care. And that's very, it's higher, that medical mistrust is higher in ethnic and racial minorities and sexual minorities. And there's a lot of data on that, a lot of studies to show that those individuals who have medical mistrust are less likely to seek care, or they're less likely to comply with recommended care, less likely to seek out preventative care. And there's a lot of historical context for that as well, and it's very understandable. What happens when we, as the health IT industry, say, let's just open up data sharing, that's such a good thing, without having that context, is we are then creating a system in which many of those people who have medical mistrust have to say, well, that doesn't include me. So I'm either going to opt not to go get care because I'm worried about the data that precedes me, or I'm going to tell my organization, shut that data sharing off, right? And if I do that, I'm shutting all my data sharing off. So now I go to the emergency room, and if I'm somebody who has data that I consider sensitive or don't want shared, right, whether that may be protected by state law, right, and so the organization doesn't share it, or I may not want it shared. Now, my meds, my allergies, right, information that would be helpful to have shared doesn't get shared, and so we're creating inadvertently disparities in care. And so I lead a collaborative of about 300 experts across North America, and what we are doing is trying to enable computable consent and the technology and infrastructure to allow patients to have more choice over how their data is shared. It's called the Shift Collaborative, and we are trying to promote interoperability, allow the patients who might otherwise not share any of their data to share most of their data, but also say, hey, there's maybe some piece of my data that I'm sensitive about that I don't want to share, and how they can do that, understand how they can do that safely.
Wow, that's actually really good. I think that's a lot of insight that people probably don't know, and that's amazing that you guys are working on that space.
Yeah.
I think it's cool. I think it's cool what you're doing, the space that you're in. You could have made different, choices in life to go do different things, and you're still, when you talk about teacher, sometimes you have this idea of teacher where you're really teaching out here, right? Look what are you doing today? You're just doing it at a different level, and I truly love it. But how do you get these tech partners? You talk about tech so much. It's like, how do you get these tech partners to really buy in when your budget can't even compete? I think that's why people don't look into innovate, because they just feel like, well, we don't have the budget.
Yeah, I think finding your value add, right, is important. For us at Cambridge Health Alliance, we have a very special patient population, right? We have a particularly diverse patient population that's ethnically diverse, that is racially diverse, that has particularly diverse language needs. And we make the case to our tech partners that, yeah, you can pilot in lots of different places, but you haven't piloted and you haven't developed somewhere that offers the diversity that we offer. And so pilot with us, and not only do we offer that diversity, but we're also academic, right? And so we have the experience of publishing and doing these these types of pilots and innovating, right, with you. And so I think finding your niche and finding your value add, right, we're not just asking them for something and asking them to say, hey, provide us with something as a safety net. We're saying we can offer something back to you, which is to provide you with an opportunity that you may not have in some of your other early development partners.
Okay, I love that. I love that. And as we start to close it up here, asking some questions for our leaders, what would you say to a healthcare exec who's actually afraid of AI, but not afraid of inequity? I'm pretty sure you hear this and probably have these conversations often, but it's happening. How would you kind of help these individuals?
Who's not afraid of inequity, but is afraid of AI?
Afraid of AI, yeah.
Well, I would say that first of all, I think that AI can offer a lot of solutions to inequity, first of all, and that if someone's not afraid of inequity, I would say there are a lot of reasons that we should be attuned to inequity in everything we do, right? That if we are not attuned to inequities, we are not serving all of our stakeholders appropriately. And so, and even at a less diverse organization than Cambridge Health Alliance, you're not going to be attuned to your stakeholders if you're not thinking about where we can mitigate inequities and mitigate bias, right? That's really important. But if someone is afraid of AI, I would say it is healthy to have, right, and appropriate to have a healthy fear, I think, and a healthy caution around AI. But AI is the future here, and if that holds you back, then you're going to be like some of those leaders and organizations that are still on paper, right, while everybody else is on the EHR. So I think it's the wave of the future. You got to get there, and you got to figure out how to get there safely and how to get there with appropriate guardrails.
They might end up like Blockbuster. Who knows?
I know, right? Yeah. You're going to get sort of outrun in your market, right? It's a market imperative at this point, to be using AI, and so yeah, exactly.
I just love the way that you just reframe innovation, so it actually serves people, not just KPIs. I mean, just listening to you, I hear that, right? And kudos to you for just thinking outside the box in a sense. But I appreciate it. We're here to the blind question. So are you excited for this blind question?
I'm excited for the blind question. Let's hear it.
Had to spruce it up just a little bit for you as well. But what's one mistake you've made in the name of innovation, and what did it actually teach you about leading with purpose?
Oh, it's a great question. What's one mistake I've made in the name of innovation? I would say that I did not push hard enough. I did not value myself and the organization high enough when pushing for and advocating for development contracts. So right, in negotiating contracts with vendors, right, at times I have not sort of driven a hard enough bargain for the organization, and I have learned from that about the value that we bring, and have learned to negotiate harder, and learned that we bring significant value, and to sort of play hardball more at the negotiating table. So that's what I've learned.
Love it. How do you think really early this morning? That's how we do it here,
Yeah, exactly.
Hannah, what is your blind question? I know we were through email. You said you were so excited you had a blind question. You were prepared for this. So what is that blind question you have for our next leader?
Yeah, I do. It's about interoperability. And my question is, imagine that you're talking to a group of residents 10 years from now in 2035, and we have finally solved interoperability, both the technical side and the human side. And they ask you, what was the real breakthrough moment when data finally started to flow seamlessly between systems, and what was the fundamental change that happened? What would you tell them about what finally all started to click for us?
Got to go back to that data, huh? Make sure she had to
Yeah,
throw that in there. I
I
see
gotta
you.
do,
I
kind
see
of
you.
bring that in there. So yeah, that's my blind question.
And I appreciate it. And
Yeah.
for those that are still watching, where could we follow you individually, but even the organization? If we wanted to know more about what you guys are doing at the organization, if we could just kind of get some more of that information for those
Yeah,
listeners.
absolutely. So you can find Cambridge Health Alliance at challiance.org. You can follow me at hgalvinmd on Twitter, or but I'm not a big sort of Twitter poster. You can follow Shift. That's better. I post a lot through Shift at https://shiftinterop.org, and all of our socials are posted on our website as well, and so that's the best place to find our socials, and that's really probably the best place to follow me.
I love it. Well, Hannah, thank you so much for your time. It has truly been a pleasure to just get more insight from the technology side of healthcare, right?
Yeah.
We speak to healthcare leaders that are doing it frontline, but never that individual that's part of the technology and seeing how we're growing. Because a lot of people have been living in fear for a very long time because of technology and the way we, as you mentioned a little earlier, we don't get that eye contact, right? It's hard when we don't speak certain languages, and I feel like you're definitely the person that is leading charge in this way, and I can imagine that you're really going to make some global impact. So I appreciate all the time that you had with us today. Guys, if you're still watching, make sure that you guys do like and subscribe. And listen, we're just so fascinated with all the leaders that we have here in the healthcare nonprofit space. But this one right here, this has been Hannah. My name's Efrain, the Heart and Hustle. We'll catch you guys on the next one. Laters.